Good evening. Good
Good
evening.
evening.
I am Dr. Naima here, one of the doctor in the clinic. Am I speaking to Miss Kate?
Yes, doctor. Miss Kate Winslet is speaking. I'm 33 years.
Okay, all right, Miss Kate. Today we're going to talk regarding your health condition. It have came to my attention that you have been having this cough. Would you like to tell me more about the cough?
Well, doctor, for the last few weeks, I have been going through a nagging cough. It's really boring, doctor. And initially, I thought it could be due to some viral infection. I took some, um, homemade remedies and also paracetamol, but things is not improving. So my
I see.
GP actually referred me to you for further evaluation, doctor. Please help me.
All right, all right. I hope at the end of our discussion we could actually help you, Mrs. Kate. Can I just know you mentioned it has been happening for the past few weeks. How long exactly the cough have been?
It's been for, 6 weeks, 1.5 months.
I
Yeah.
see. All right. Can you describe me the nature of the cough? Is there any production of phlegm or is it dry?
No, surprisingly not. My GP asked me the same question, but the cough is, producing nothing.
I see. I see. Okay. And do you notice that is have you ever cough up any blood?
No, no, not really.
No. Okay. Can I just know, is there any particular of the day that you notice you cough more? Like, do you cough up more at night or in the morning?
I think it's more on the night time, doctor.
I see. Do you notice that you have any difficulty in breathing associated with the cough?
No,
Okay. Is there any chest pain associated with the cough?
I'm s- chest pain is not the appropriate. I would say some discomfort I can feel. Not feeling good, something like that. The better term could be discomfort, okay. And one thing I would like to add here is not only in the night time, but on the just after lunch, when I just take some rest that time also, I feel the shortness of the cough is also appear.
Okay. Mrs. K, can I just know what do you work as?
Mm, I'm a software engineer, doctor.
And okay, do you notice that your cough gets worse at workplace?
Mm, I did not notice in that way. I would be watchful from next
Okay.
time.
Do you notice that you don't cough more over the weekends?
I don't think so. Anything like that.
All right. Okay, all right. Mrs. Kate, I do have some other series of questions to ask. I hope you don't mind.
Yeah, you can.
By any chance, do you have any hair loss?
Any hair loss? No, doctor. My hair is fine.
Okay. Is there any redness of your eyes recently?
No,
Any dryness of your eyes?
dryness. No, no.
And okay, is there any rashes around your body anywhere?
Rashes. I don't think
Mm,
any rashes is there. No.
okay. Do you have any recurrent mouth sores?
Recurrent. Sorry?
Mouth
Recurrent?
ulcers.
Mouse?
Mouth
No, doctor.
ulcers.
No.
Okay. All right. Is there any lumps or bumps around your body?
Mm, I did notice. Nothing like that, but you can check it, doctor.
Okay, sure. Do you notice any neck swelling at all?
Neck swelling. My GP
Mm,
checked it, okay? I'm pretty
mhm.
confident. No, there is no neck swelling.
Okay. All right. You mentioned that you is there any racing and pacing of your heartbeat?
Right now it's fine, but
Mm,
yeah, sometimes I feel that, particularly during cough, okay? I feel some
okay.
heartbeat, rise up, okay? That time I feel racing, pacing.
Okay. By any chance, do you have any joint pain?
Any joint pain? I don't think so,
Mhm.
anything like that.
Okay. Any difficulty in swallowing?
Difficulty in swallowing. Swallow, no problem with that.
Okay. Do you wake up at night gasping for air, Mrs. Kate?
It happened, doctor. The last week, the same, all on a sudden, just after sleeping,
Mm-hmm.
around 12 a.m., I just wake up from the sleep due to, boring cough, and it happened, doctor. Yeah.
Okay, all right. By any chance, do you notice that at night you have a lot of night sweats?
No, no,
No. Any shivering at night?
no. I don't think
Okay.
so. No.
Is there any tummy pain at all you experienced in the past 6 weeks?
Tummy pain?
Mm-mm.
I would say no, and no, there is no tummy pain.
Any changes in your weight recently?
I'm pretty fine. I mean, my weight is stable.
Okay. Any loss of appetite recently?
Uh, I would say it's not loss of appetite. Sometimes I feel, I mean, not interested to take food, okay, because the cough actually boring me for the last few days in a very severe way. So sometimes I miss the meal, doctor.
I see, I see. Okay, all right. Is there any leg swelling at all?
Leg swelling.
Yeah.
So for now, you can check.
Okay. Can I just know in the past, do you have any medical condition that I should be aware of?
Mm, I have bronchial asthma
I
since my
see.
childhood, and that's the one condition. And recently, I've been diagnosed with high blood pressure, doctor.
I see. Okay. Do you regarding this bronchial asthma, when was your last attack of your bronchial asthma?
It was 5 years ago, doctor.
Okay, all right. How about any condition that runs in the family?
Mm, my mother had diabetes, and
Mm-hmm.
my father had, I mean, COPD, doctor. It's lung condition.
Okay. Can I just know at what age did your father had COPD? Was it at a young age or when he is a little
No, I
bit
mean,
older?
at the age of 65, he was diagnosed, and he was actually chain smoker. Doctor said his underlying cause is actually smoking.
Okay. All right. Mrs. Kate, are you on any medication at all?
For my asthma, I'm taking Montelukast at the night time, and I just keep my salbutamol inhaler with me just for precautions, but I usually don't require that. I'm pretty
Okay.
fine with Montelukast.
Okay. Is there any over-the-counter medication?
Yes, I mean, for the last few days, I'm taking different cough suppressant, okay, prescribed by my GP, but the things is not improving.
Mm-hmm.
And even I was thinking it could be asthma, so I increased the dose of the Montelukast, okay, and also
Mm-hmm.
started to take doxyphylline, but the things is not improving, doctor.
Okay. For your high blood pressure, what medication are you on?
I'm taking olmesartan,
Sorry, what was that?
olmesartan.
Okay. All right. Okay. Mrs. Kate, I do have some sensitive question to ask you. By any chance, do you smoke?
I used to smoke during my university year, but I quit long before, doctor.
Okay. How long did you stop smoking?
7 years ago.
Okay. How much do you use to smoke?
I'm occasionally when I hang out with my friends, one or two sticks, not more than that.
I see. By any chance, do you drink alcohol?
Socially, after
I see.
lunch or dinner, half glass of wine.
All right. All right. Mrs. Kate, are you married?
I'm planning, doctor. I mean, I'm looking for, but not yet.
Okay. Okay, Mrs. Kate, is it okay if I examine you?
Yes, doctor, you can.
Okay, so first of all, I would like to take a look at the patient. How is the patient well-being? Is the patient cachectic looking?
Patient, as you can see on the screen,
Okay, so I would like to check for any CTD's features for the patient. So first, I will proceed with the hand. Is there any joint deformities of her hands?
no,
Any
hand is
skin
completely
rashes?
fine. No,
Okay. Is there any psoriatic nail changes?
psoriatic nail changes. No,
Mhm.
there's no
Okay.
change in the nail.
Okay. How about the pulses? Is it regular on both sides?
Pulse is 65 beat per minute, regular, normal in
Mhm.
volume.
Okay. And then I would like to check for the eyes. Is there any pallor or jaundice?
You want to check the eyes, right?
Yeah.
Can you see it?
I think there's some sort of pallor. I think. Yeah.
hmm
Okay. Then I would like to check for the face. Is there any malar rash around the face?
As you can see,
Okay. Any cervical lymphadenopathy palpable?
you're checking the lymph node, right?
Yes.
Okay.
Yes.
So in the neck, there is no lymphadenopathy.
Okay, all right. Then I will proceed with auscultation of the lungs. Is there any crepitation heard?
Fine. Okay, let me guide you. Okay. You have to identify the area. I mean, switch the area. Just guide me. What do you want to check?
Okay, so I would like to check the posterior aspect
Yeah,
from
this is the
upper
posterior
zone
aspect, upper
uh
genitomiddle.
so
Mhm.
from upper zone to lower zone. Okay,
This is the left side.
okay,
This is middle gen. Let me know when
okay,
you want to change the area.
okay,
This is the left
uh,
side.
okay,
This is the lower zone of the right side. This is the lower zone of the left side.
okay.
You have 2 minutes left. We are practicing 30 minutes. Okay, fine.
Oh,
Carry
okay, okay. Can I just quickly check the trachea of the patient? Is it central?
trachea is in central position.
Okay. Mrs. Kate, can I just ask you one last question? By any chance, do you have pets at home?
No, doctor. I mean, I have pet. It's been for the last 10 years. It's a
Mm-hmm.
dog.
Oh, it's a dog. Okay, all right, okay. Oh, before that, can I just ask, is there any loud pichu?
And loud pituitary. So
Mm-hmm.
pulmonary area, right?
Yeah,
Okay, maximize your microphone sound. Probably you can hear some sound.
okay. Can I just quickly auscultate the other part of the precordium?
Which area? Which area? Let me
Mitral
guide.
region.
Mitral region.
How about the tricuspid region?
Tricuspid region.
Aortic region? Okay. All right. Okay. Mrs. Kate, can I just know what will be
Mhm.
your concerns, Mrs. Kate?
So, doctor, what's wrong with me? I mean, I'm thinking, is it my asthma or my other, also, my friend is talking, it could be something, I mean, cancer in my food pipe. They're thinking about, I'm very concerned about that. What do you think, doctor?
Okay. All right. So, Mrs. Kate, after examining you and also listening to you, I think you might be having a condition called it could be the exacerbation of the bronchial asthma, perhaps because they might not be well controlled with the medication. But the other thing
No,
that I
doctor,
am
it was pretty well controlled. I mean, so far, I mean, I don't know. So far, it's been well controlled for the last 5 years.
I see. The other thing that I am worried is that we might have to work you up for some sort of uh tuberculosis as well. Have you
Time up,
heard about this?
time up, complete. I mean, 40 minutes, 15 second. Okay. Fine. You said about tuberculosis. I'm asking for the. I mean, I'm going for the crossing part. Then we'll back to the discussion. Okay. Now your crossing is starting for 5 minutes. Can you present your
Mhm.
positive findings from history and examination?
Okay. So from the history, I have gathered that the patient have a 6 months history of a dry cough with associated of
Six
um
weeks.
6 weeks,
Not
sorry,
much.
6 weeks of a dry cough with a background history of bronchial asthma and also hypertension. Otherwise, no other significant history besides that she was a ex-smoker who stopped 7 years ago. And there was an associated of a loss of appetite as well. And on examination, I couldn't locate any CTD related changes. And on auscultation of the lungs, there was wheezing heard over the upper zone with
Mm-hmm.
normal air entry over bilateral lower mid to lower zone.
Mm-hmm.
Precordium, there was no features of pulmonary hypertension as well.
Mm-hmm.
So, putting all this together, I think what I would like to work out for Mrs. Kate is that it could be lung malignancy, given that the history is 6 weeks of cough with a loss of appetite. The other possibility that I would like to work out is tuberculosis as well, given there
Mm-hmm.
is a dry cough. And I would like to also assess for the exacerbation of bronchial asthma as well.
Okay, so your first differential is lung carcinoma, then second is tuberculosis, and third is bronchial asthma. Okay, so can you tell me one or two justification point? As you said, the lung carcinoma is your first differential. What other points did you get
Okay,
apart from the
so
cough?
apart from the cough, the patient do have a smoking history in the past,
Is
and
it
there is a
significant?
consider um not really, but any amount of smoking should be increase the risk of lung malignancy.
Mm-hmm.
Secondly, patient do have some sort of constitutional symptoms such as loss of appetite. Although the
Okay.
examination finding did not suggestive of lung malignancy. In terms of tuberculosis, given the prolonged cough of 6 weeks with nature of the cough being dry cough, TB needs to be
Mm-hmm.
ruled out as well. And bronchial asthma is the least likely. The only justification I could get is that there was a wheezing heard over the auscultation.
Fine. How you want to confirm your first diagnosis or
So, in terms of diagnosis,
diagnosis and how to rule out the other?
okay, so in terms of investigation, first I will start with a baseline investigation, which include full blood count to look for any form of infection, renal profile, and also liver function test, mainly for pre-medication initiation baseline. I will subject the patient with a chest X-ray, mainly to look for any consolidation that could have triggered the cough, any miliary
Mm-hmm.
nodules from the chest X-ray, and hyperinflated
Mm-hmm.
lung, given that the patient have asthma, and also whether there is an obvious opacity that can rule out malignancy. And in terms of diagnostic, will be a CT thorax, contrasted CT to look for the
Mm-hmm.
finding. Concurrently, I would like to assess the patient's lung function test as well to look for restrictive versus obstructive pattern. And
Mm-hmm.
I would like to also rule out any pulmonary hypertension by performing an ECG and also echocardiogram, although I don't think that is the case in this patient. Otherwise,
But
I will
mhm.
also subject the patient with blood gases just to look for the oxygen saturation.
As
Um,
you already given, so saturation is pretty fine. Okay, so how you want to manage this patient in terms of
so,
treatment?
okay, in terms of treatment, given that the patient's vital sign is stable, I would like to just work the patient out as an outpatient. It will involve a multidisciplinary team approach, which is non-pharmacological and pharmacological approach,
Mm-hmm.
whereby we will co-manage the patient with a respiratory physician,
Mm-hmm.
education and counseling regarding the patient's condition, and I would co-manage the patient with physiotherapy for the chest physiotherapy. In terms of definitive management, it will depend on the etiology. If it
So
is turned
in
out,
a dry cough setting, okay, Dr. Naima, just sorry for interruption. What you mean by chest physiotherapy that can help the patient when patient has dry cough?
um, I
Okay, carry
think
on, please.
I think in terms of it's a breathing exercise rather than productive to
Time up.
term.
Complete 5 minutes time. I mean 20 minutes. Okay, we just completed. Okay, so how does it goes, Dr. Naima?
I think I am sorry. I don't know the diagnosis, to be real honest.
No problem. I mean, in the basis, actually, the approach is very important rather than get the diagnosis. When your diagnosis differential within the list of differential, that's completely fine. But if not, then it becomes problem.
Yeah.
So I mean, along this calibration, what do you think? I mean, the differential, did you say lung carcinoma and tuberculosis in your first and second? So if you have been given the second chance, would you like to consider this or anything else?
The only thing I think I did not consider in the STEM is that I didn't rule out sarcoidosis in this patient.
Okay, okay, fine. We'll discuss the case definitely in great details, but before going to discussion part, I would like to interact with other candidate. Okay, based on the calibration, I mean, what you are thinking, other guys, please unmute yourself or join in the conversation in the chat box. Then we'll discuss the case because I always verify my calibration is well or not. Because if anyone among these 20 people got the diagnosis in the chat box or comment section, then the calibration is completely fine. It's my way to verify my calibration as well. So looking into the fine, any comment? Okay, I can see there's a comment is there. Okay. May I know when the AC inhibitor was started? No, actually, RV was started 2 months ago. Dr. Ressi. Okay. Yeah. Anyone has any other differential? And that's a very good question, by the way, Dr. Ressi. You asked me when the antihypertensive medication was started. That's a really very good question. Dr. Naima did not explore that. We'll discuss that in the history part. Okay. Any other comment? I'm asking everyone to be active and interactive in terms of, I mean, putting some differential, what you are thinking as a differential in this case. You can unmute yourself or you can also let us know in the comment section. There is no other comment. Okay, fine. Now we are going to the discussion part. Okay, so this case actually was a GERD. Dr. Naima.
Okay.
So now I'm coming to the point, okay, why GERD the cases, okay? So from the very beginning, the cough is non-productive, okay, which is usually at the night time, at the midnight. The recent one, when patient wake up at the midnight, okay, and usually in GERD case, patient usually presented with a nagging cough or boring type of cough or irritation in the throat just after lie down, okay, probably 1 or 2 hours, within 2 hours of the last night, okay, last meal. Because when patient
Mm.
lie down, due to GID, I mean, the acid reflux come in close proximity of the throat and it causes irritated and nagging cough, which
Okay.
almost similar to, I mean, cough variant asthma, or sometimes patient has some dry cough or for other problem like IFA. So in this case, I put the calibration in a little bit atypical way. It's not atypical. In many centers, actually, the calibrated the case along with some wheezing in the upper part. And interestingly, why in the upper part of the lung, unaudible, on auscultation, there is some wheeze. In GRDs, it's uncommonly common. What I mean by that, when the acid reflux happen, okay, so larynx become narrow, spasm happen, some degree of spasm happen. So due to, I mean, inadequate air entry, okay, as well as also air passing through the larynx, there in the upper zone, you might experience some wheeze, okay, which is completely absent in the middle zone. There is no wheeze or no crackles in the middle zones and also lower zones. This is one of the rare, but it can be common, okay. But if you look at the history, patient is completely fine. There is no past medical history apart from the asthma, which is well controlled. Cough is only at the midnight, okay, not in the early morning. Okay, there is no allergies, and patient has paid for a long time. So this clearly, I mean, excluding the asthma, and patient, according to the patient's statement, patient is well controlled. And last time he admitted due to asthma problem 5 years ago. It's a very distal part of the recent hospitalization, right? So that's completely excluding the bronchial asthma because patient give the history. I'm completely fine with the medication, and I started increase the dose of the Montelukast, start doxycycline. Still, the situation is same. So it means there is something else. Okay,
Okay.
so bronchial asthma is excluded by far. Now coming to the second point, okay, it can be many other reasons. It could be lung carcinoma, as you said. Okay, so does this patient has any red flag that can push towards the lung carcinoma? You took the history of smoking. That's really good, but the smoking history is very negligible here, right? I mean,
Mm.
he actually stopped smoking 5 years ago, and prior to that, she took 1 or 2 sticks, which is, I mean, very significantly very low amount, okay, to turn into a
Yeah.
lung carcinoma. And apart from
Okay.
this patient doesn't have any polyphonic voice or COPD like, I mean, presentations, okay? There should be some other paraneoplastic features. In the hands is completely fine. There is no other feature of hypercalcemia.
Mm.
Patient weight is stable. So that's also, I mean, clean cut, ruling out the lung carcinoma. And you said TB, tuberculosis. I don't know, in the absence of hemoptysis, without exposure, and in the absence of lymphadenopathy, TB can be possibilities. If you put into a differential, you have to show some logical point. Otherwise, examiner will cut the marks. In the basis, one
Mm.
of the good advantages, if you have very good justification point, you can put put something as a differential. But if you don't or cancel one logical point, in that case, they will just cut the marks, okay, and give you the unsatisfactory. In this case, I mean, TB is not even near. Patient doesn't
Okay.
have any exposure, no lymphadenopathy, weight is fine. And one of the things you put, I mean, pick from the examination, does patient has anemia? I don't think so. It's completely fine.
Okay.
It's completely fine. So a patient is not anemic. Okay, this is the completely normal eye, and I put it here to stimulate okay real exam like situation. In the real exam, it will happen. Okay, so I mean TB in case of you want to put TB into your differential, there is at least 1 or 2 features should be there. Patient has recent contact with the chesty patient, hemoptysis, productive cough, weight loss, night sweat, okay, some lumps and bumps in the form of lymphadenopathy. There should be something. Everything is absent. Okay, so TB is also potentially rule out. And any recent travel history, which is a very key and important history, which was missed. Okay,
Mm. Mm.
and now coming to the GERD. Why it is GERD and what are the common and most important history was missed. Okay, when a young patient has cough and past history of asthma, definitely asthma always conflict in your differential, okay? Because this is how they will calibrate the case. Otherwise, it will be a piece of cake to pick the diagnosis, okay? So you have to take few history very specifically. When the cough appear, is it the midnight or just early morning, okay? For any particular time of the day, any particular season of the year, there are a few histories very important. Okay, you said it's you wake up in the last night or 3 days ago at the midnight. Okay, okay. So during that time, did you took cough or any other problem? Doctor, no, there's some irritation in my throat, and I said twice, doctor. So irritation on the throat means there is some acid reflux. So the both WBC is an acronym. Is actually common in both GERD case as well as asthma case. GERD means, I mean, W for wheezing. Wheezing can be in both case asthma as well as rarely in GERD case. In more common in the asthma, right? But in this case, particularly water brush can be a very good time. Okay. I mean, did you test, I mean, bitter or only morning bitterness? Okay. Or there is any water brush is there? You can simply ask that. Okay. Before burning chest pain, you did not even ask me what you mean by discomfort. Is the patient language, okay, I'm feeling discomfort. You have to extractive and convert into your language. Okay, how you can do what you mean by chest discomfort. Is it chest pain or chest tightness? Then patient said, doctor, it's not chest tightness. Actually, it's something burning in my chest, particularly when I take heavy meal or when I take meal. Simply, it's a big clue. Okay, so before burning chest pain. But in case of asthma, this is breathlessness. Breathlessness. I'm just discussing the two things parallelly so that you can relate. Okay, and C4 cough. The pattern of the cough is nagging, boring, irritating cough, mostly in the GRD. In the other case, bronchial asthma, COPD, lung carcinoma, there is high degree of chance the cough will be productive, either white or brown. If it is actually in favor of the lung malignancy or tuberculosis, they will give, okay, doctor, yes, last month or last week, I have a episode of hemoptysis, I mean blood mixed cough. Okay, so they will give some history of cough. Okay, so C for cough and C for chest tightness. You can remember also C for chest tightness. So this WBC actually the three important history that can help you to pick the diagnosis. Water brush is very important. Bitterness of the chest in the mouth, particularly in the morning. Okay, or sometimes patient may present a doctor. My mouth is smelly, foul smell. Okay, it's an indirect history. Okay, due to GERD, patients sometimes presented with some, I mean, breath, bad smell in their mouth. And C for cough, actually cough and also chest tightness. And sometimes the chest tightness almost similar to ischemic heart disease. After taking meal, doctor, I feel some chest tightness. They will not say cough. They'll say some chest tightness. Okay. So then ask few other history. Okay. Ask about there. Let me take a new slide. So there are few histories very important. Their lifestyle. Lifestyle is very important. My lifestyle is very important because most of the lifestyle is related to the GRD. Smoking, you asked me about the smoking. Patient was a past smoker. So potentially ruling out, okay, this risk factor is not um, present in this patient. Okay, that can, I mean, pull towards the lung carcinoma or exacerbation of COPD or bronchial asthma, but patient is not a smoker. What about the drinking? Patient sometimes, in most of the cases, in the calibration, they will say, doctor, I'm a heavy drinker. Okay, or they will say I'm a drinker, I'm an average drinker. Okay, drinking, and ask about their meal. Okay, meal. They usually prefer a fatty meal. They usually lie down just after taking the dinner, and how much pillow they use in the night time. Okay, these are the most important history. Is there any relation with the meal? The cough appears just after meal. Yes, doctor. When I just lie down, okay, after 1 hour or 2 hours sleep, okay, I just wake up. There is some irritation in my throat. Okay, so these are the most important history. And you missed few history, particularly the bitterness of the taste and the water brush and the chest tightness. You did not explore that. Okay, you rather ask about few default history, usually not required in this calibration. You ask about rash, you ask me about joint pain, and also ask me about few other things. Okay, but you also examine the lymph node. That's really good, but you did not check the mouth cavity. And sometimes in a case of GERD, sometimes dental caries or dental erosion will be there due to recurrent GRD or long-term GRD. Patient might have some, throat, inflamed throat or redness of throat. In this case, luckily, patient doesn't have any features. I just keep it normal. Okay, and it also, makes you a strong candidate in the eyes of the, patient examiner that you are potentially excluding any esophageal carcinoma or esophageal or just food pipe problem, okay, by looking and lighting on the mouth cavity. So you did not check the mouth cavity, which is very important to check to exclude the pharyngeal, any pathology is there or not. Okay, you check the lymph node and track it. That's really good. And you said any tummy pain. I did not say anything, but an excellent candidate definitely try to exclude any problem in the GI level. Just have a good looks is enough. Okay, if I give you some history, like I have past history of peptic ulcer disease, or I have some tummy discomfort, that could be easy. But at least I would say, as an excellent candidate, you have to have a good looks on the tummy as well. Okay, which is very important. And in the Royal College calibration, in the examiner sheet, there's sometimes, I mean, there are some category: an average candidate, an excellent candidate. That line is like this. Again, an excellent candidate will check these and that, and a good candidate will check these and that. So in this case, if you look at the patient's expression, that's also, I mean, tell us many things. Look at the patient's hands. They just put their hands in the middle part. I mean, more towards something, not towards the cough. It's something in the chest, right? It could be some heart pain or heartburn. Okay, so always put every dot with equal importance. And when you connect the dot, it will make sense. Okay, isolated dot will not make sense. I give you another clue. You can say distractor is recently been diagnosed with hypertension, and I started almost certain. And by the way, ARB usually doesn't cause any cough. Okay, a inhibitor can cause cough, dry cough. Okay, but ARB less likely. As a potential, I mean, distractor, I asked that, and that's why Dr. Rosie also put it a very good history. Yes, when did you start the medication, antihypertensive medication? What is the medication? Is there any recent change of the medication? Is very important to ask that. Yeah. So, any questions from your side, Dr. Naima?
I think because I did not consider GERD as one of my differential diagnoses, so I
Mhm,
think that was the issue. I didn't get the diagnosis.
mhm. No
Mm.
problem, but definitely say, I mean, it's a, I mean, learning. We are all learning, but there are few history encrypted in your mind. Okay, by practicing this type of case, that what should not I miss in a case of cough, right? And I'm pretty
Okay.
sure from today, definitely in a young patient setting, when patient has cough, you will take this into your consideration. But there are few, I mean, for the discussion purpose, I would like to add what the case could be like in other way. Patient usually, GRD patient usually a little bit bulky. Okay, sometimes they are they are actually, their BMI actually a little bit on the higher side. They're usually drinks a lot, and they are foodie. Okay, they love to eat junk food, fatty food, fast food. Okay, so these are the, in common eyes, it may seem it's not important, but if you just look into their lifestyle, you will get something erratic. Okay, they are not a very disciplined person. Okay, they take their meal late time, sometimes miss it. Okay, they love to eat and hang out in outside. Okay, take lots of junk food, fast food, and BMI is in the high. And there are a few other histories important. Is there any night so? Okay, any does you make create any sound in the during sleep time? Probably they can't say, but their partner will. Because these are the history, because post-nasal drip will also come in the equation. Okay, in this type of scenario. So just, I mean, recapping, the their focus history is very important, particularly WBC is very important. Then to exclude the red flag as an excellent candidate, you have to ask what, okay, is there any weight change, any appetite change, any lumps and bumps is there? Okay, and also tummy. Checking the tummy is very important. Okay, tummy is very important. So that's why I picked the pictures here. In the eyes, it's a distractor. There is actually no anemia. Patient is completely fine. And if you want to check in a subjective way or objective way, take the objective view. Okay, did anyone say that are you getting pallor divided? This is the objective view, and subjective you are, I mean, looking yourself, okay, is there any anemia or not? It's clearly patient has red eye, okay, I mean normal eye. Lower palpebral conjunctiva is completely normal, red. There is no pallor. Yeah, yeah. And if you look at the mouth, yes, you have to check the mouth, and you have to also check the cervical lymph node, okay, and check the back and precordium. You check that to exclude the cardio as well as resp cause. Okay, in this case, patient has apical voice, um, which is pretty uncommon. But I just put it here due to laryngeal spasm. When some patient has laryngeal spasm due to acid reflux, that sometimes they may present to wheeze, okay, which is really uncommon in exam setting. But I just put it as a calibration to make the calibration a little bit tighter and trickier, okay? So hopefully in the real exam, they will give you the normal lung. Yeah. In the heart, there is nothing abnormal lumped up in everywhere. Okay. So now for general discussion, what are the common features usually patient presented with? So chronic cough, wheeze and a worseness of the voice. So you can also ask, okay, did you notice any change in your voice? And irritation is a very big word and big clue, because in some word, in some case, actually give you the clue. So word based, I mean, thinking also is important when someone say, okay, dysphagia usually suggests complication or late findings, usually does not present in that way, but one of the key histories when symptoms appear. Even if you did not ask me when the cough become worse or better, if you ask me, probably you could, I mean, get us some good information that was missing. Okay. Risk factor, obesity. Sometimes patient with pregnancy may present with that, and sometimes patient has long-standing esophagitis may present it with GERD, okay, or later on may present with Barrett's esophagus. Okay, so we should keep it in our mind. So what are the focus history? I always say in the cases there are lots of history you can take, but you have to wait. Okay, I have to touch 7 scale within 15 minutes, and I don't want to fail in any scale. Rather be average. I mean, touch the baseline and complete the mandatory and basic history rather than taking all details. Sometimes it may take 11 minutes. So it's not a wise approach. I would say take focus history within 8 to maximum 9 minutes, do exam and perform necessary exam in a very focused way, 4 minutes, meet the concern with 2 minutes. You will end up with 25-6 is well marked. Okay. But don't try to be perfect, taking all the history to get the diagnosis. It will lost. Okay. And every step subsequently will be affected. Your exam will be rushy. You will miss the important findings or pick the wrong one. Okay, so sign creation will happen, physical sign will be affected, exam perform, physical examination will be affected, and concern meeting definitely would be rush. Okay, so all the skill will be affected. So rather, right allocation of the time, focus history, focus examination, meeting the concern, and also addressing it in a very well mannered. I mean, covering all the main points. Okay, so in this case, concern was completely missed. Concern was completely missed. So you have a condition we call GERD in a medical language, where the acid from the stomach or food sac, I mean, coming back and causing some irritation and cough, okay, in the throat. That's why you are having these problems. Usually it happens when someone body weight is excessive. In your case, probably you are going to bed just after taking the meal, okay, or spicy food. Depends on the patient history. So we're planning to do some investigation to exclude the other potential or serious one, as you were concerned about the cancer, and same time would like to confirm it. We might need to do a camera test, okay, to see any sore or any growth is there or not. And in the meantime, we'll involve the guard doctor. Okay, we might need to you need to start a medication called proton pump inhibitor that will keep your acid secretion in the food sac under control. Okay, that's it. And if time is still there, you can address the lifestyle. That would be better. Okay, so we will usually advise to take the meal on time. Don't make any delay. And after taking the dinner, you should at least, 2 hours gap in between the last meal and go to bedtime. Okay. So avoid spicy food. Okay. Keep your weight under control if the patient is obese. These are the most common safety netting you can prescribe to the patient. Okay. And definitely in this scenario, excluding red flag is a must and mandatory. You excluded that. That's really fine. You also try to take the history in the line of asthma and S inhibitor. In this case, although I give the ARB. Okay. So focus history about the abdominal examination. In this case, although I did not give any dysphagia, something like that. If I say a past history of peptic ulcer disease, definitely abdominal examination will come in the equation. BMI asks that. Okay, and at least open the mouth. Okay, check the uh, I mean esophagus, upper part of the esophagus, oropharynx. Okay, to see any and check dental erosion is there or not. Respiratory, definitely, as patient has asthma. And red flag, anemia and weight loss. You check the trachea, that's really fine. And also lymph node. Yeah. So what are the differential in this case? Particularly in this case, I did not put the asthma in this equation at all. Okay. GERD, peptic ulcer disease, and sometimes patient has functional dyspepsia when patient is going with tough time or anxiety issues there. So in that case, functional dyspepsia can come in the equation. And achalasia can come in the equation, but it needs a proper calibration. For example, just patient around 55 years, usually female, okay, then nocturnal cough, not nocturnal cough and nocturnal tightness. Okay, so this is the typical history usually. Sometimes patient regurgitate the food. Okay, so these are the typical history of achalasia. But in the achalasia, patient should present some dysphagia. Okay, solid or liquid. But in this case, the history is not in that way. Okay, esophageal malignancy down on the list. Okay, biliary colic probably will not come in the equation, particularly in this scenario. Point investigation. Esophageal pH monitoring is very important. I don't know, Dr. Naima, did you mention? Dr. Naima, are you with me?
I don't think so. I mentioned it, doctor.
Yeah. So endoscopies, mass, CBC, yes, as a basic test, you can do that. And manometry, pH, 24 hours pH checking is important. Endoscopy is very important. Okay. The advantage of doing this, by doing this, you can exclude these potential three, right? Peptic ulcer disease, you can do endoscopy, GERD, okay, 24 hours pH monitoring, and achalasia for achalasia, manometry, okay, lower esophageal sphincter pressure, okay, you can measure. So treatment, actually lifestyle modification, give the proper advice, weight loss. If the patient is completely fine, weight is stable, in that case, give the advice like, okay, just elevate your head and use two pillow, okay, or whatever you comfort with. Then I would trigger like food or late meal, okay, proton pump inhibitor for the first line medications, right? And sometimes prokinetic if the patient has any nausea, vomiting like features. Fine. So up to this point, any questions from anyone? Any questions from Dr. Naima first regarding this scenario?
No, doctor. I think I, I,
Okay.
I should put that in my pressure next time.
Yeah. Okay, fine. Thank you. And if anyone has any question, please feel free to ask. So secretary, yes, you asked me GRD and ARB. Fine. It's a very good differential. And convenient asthma, by the way, yes. Not asthma, convenient asthma is more appropriate in this differential. So I hope the calibration was fine. Okay. So if there is no questions, we can conclude the session. If you have any questions, you can ask me regarding this scenario or any scenario you can. Okay. And lastly, we have just one slide. Just hold on. There's some quiz part. Okay. So, what common things common. Now, Dr. Naima, if you are able, you can answer the first two, then other candidate will do the last three. Okay, so what could be the first two? And by the way, the diagnostic quiz creation purpose is only to give you the message of what actually matters. What is the key history that actually help you to sort out the diagnosis? Okay, so first, the first quiz. What would be the first quiz? Anyone on?
Uh,
Mhm.
I'm so sorry. I started driving already.
No problem. Okay, please safe drive. Okay, the other candidate can join. Yes. Anyone? I don't know why. Oh, no one is interested. Okay. Anyone can tell me the first differential as we just discussed, right? This is actually GERD. The second one, is actually in heart disease, right? Ischemic heart disease. The typical history will be like this. Okay, central chest pain, radius to any particular territory. I mean, all jaw and upper limbs as well. And the third one, the third one is dysphagia, weight loss, supraclavicular. So if you look at the scenario, these are the red flag, right?
Yes.
Importance. So when any scenario is calibrated in align with the carcinoma, at least one of these three history will be there, right? And it can be in the form of yes, weight loss, pallor. This is esophageal carcinoma or upper GI carcinoma is the broad term, okay? And the fourth one, the fourth one,
Peptic ulcer disease.
yes, when patient has localized tenderness, peptic ulcer disease. So what actually the picking point here? You are not picking the diagnosis based on whole syndrome. There's some word. That's why I stress on some word. Some word actually guide you what might be the diagnosis, right? So clavicular lymph node and dysphagia, esophageal carcinoma, exertion of chest brain radius. These are the keywords. So in each scenario, there are some keyword. If you focus on that, it will be really easy for you to pick any diagnosis. Okay, and regurgitation, nocturnal cough. Although I give the just extra findings in the exam, definitely they would not. So this is actually achalasia or hiatus hernia. Hiatus hernia or achalasia, both can come in the equation. So thank you for joining, and thank you for your participation. If anyone has any questions, you can ask me now, or you can also ask later on the WhatsApp group. Thank you and see you soon on the next session. Okay, thank you for joining. Good night.